Hi, this is Dr. Aaron Kowaleski at ECCO Medical. If you're watching this video, it's probably because you have recently had some imaging studies and likely have some form of vascular disease. Specifically, right now, we're going to be talking about peripheral artery disease, or PAD. Symptoms frequently associated with PAD are leg pain with walking, which is also called claudication, meaning the further you walk, the more calf pain specifically that you can experience. Other things like atrophy of the muscles in the calves, meaning that they can get smaller over time. You can have hair loss, skin discoloration around the feet and ankles. You can get purplish or even blackish discoloration in the nail beds in your toes. And in worst case scenarios, you can even have wound development or ulcer development of your toes, your ankles, or your feet. Diabetics, they may have masking of a lot of the pain symptoms because they can have neuropathy where the nerves don't work to really let them know that they have pain. However, they are more likely to develop the ulcerations in the wounds that I already mentioned. So who gets PAD? What are the risk factors of it? Why do you potentially have it? Risk factors for developing PAD include diabetes, smoking, high blood pressure, high cholesterol, diet, obesity, and age, meaning that the older you get, the more likely you are to develop PAD. It affects men and women equally. Hispanics and African Americans are more likely to have it than the general population. And as far as numbers go, about 1 in 20 people above the age of 60 have some degree of PAD, and that number increases with every decade of age. So what exactly is PAD? The way PAD develops and why it develops is because with those previous risk factors that I mentioned, those can cause circulating things that can cause inflammation in your blood vessels. So the overall prevailing theory is that an injury will occur to the inner lining of an artery, which then stimulates an inflammatory response to help heal that injury. Part of the healing process is to lay down cholesterol as a base to help close any injury that can occur on the inside of a blood vessel. This inflammatory reaction can be augmented to a point where it lays down too much cholesterol, so it creates a cholesterol plaque or plug. Over time, that inflammation leads to calcification of that plaque or plug, which can then create a narrowing inside the blood vessel. And with that cycle or that snowball effect of the inflammatory process happening over and over again, it can lead to a complete blockage. The plaque buildup, we separate into two kinds, soft or hard plaque. The soft plaque is just the cholesterol-based plaque that builds up, and then the hard plaque is the calcified plaque. Most people have a mixture of both kinds of plaque. Most people that do have PAD have both kinds. Some people are dominant in one or the other. That does change the way we do our treatment. It just changed the outcomes as well. But we offer all the treatment options here at ECCO to treat both kinds of plaque. Most people in the general population are actually going to be pretty familiar with plaque buildup. They just may not know it. Everyone knows what a heart attack is, and everyone has heard of plaque buildup in the heart. PAD is the exact same disease process as what occurs in the heart causing a heart attack, except it's just in your legs instead. So the way I like to phrase it to patients is it's essentially having a heart attack in your leg, but instead, if you have a heart attack, obviously your heart is going to be more important, but in your feet and your toes and your legs, that's usually when you have things like wound formation and amputation instead of a heart attack. To diagnose PAD, there's a number of studies that can be performed. At ECCO Medical, we do one study, we can call it a blood pressure cuff study. It's called a pulse volume recording. That's when we put a blood pressure cuff on your arms and on your legs. And what we're doing is we're comparing the pressures in your legs and your arms. They're supposed to be about the same. If you have a narrowing or a blockage in your leg, that pressure will be quite a bit lower. So we're looking at that functionality relative to your arms, which very rarely have any kind of artery disease. The next thing we do are vascular ultrasounds, or something that's called an arterial Doppler, where it's just an ultrasound probe. It's non-invasive. You're just taking a look at the blood vessels themselves to getting an anatomic evaluation of the blood vessel, but also a functional evaluation to make certain it's able to push blood down to the feet and toes. Another study that can be done, especially to evaluate arteries in the abdomen and the chest and the pelvis, is going to be a CAT scan or a CTA or a CT angiography. We order those if the ultrasound doesn't give us the information that we need, or if we suspect that you have issues with your aorta. So there aren't too many treatment options for peripheral artery disease. There's essentially two. We have the surgical option, which is a bypass, or the minimally invasive option, which is what is called an arteriogram. So a bypass is when they take a vein or a piece of Gore-Tex and they tie it into one side of the artery and then into another part of the artery further down the leg, because the artery in between, the native artery, is blocked or severely narrowed and can't push the blood down to the foot. So they create a bypass, just like a traffic bypass that you would see in a city. In this case, it's about 85% effective at solving the issues caused by PAD. However, there is about a 33% complication rate, either involving the graft or the bypass failing or an infection at the incision site. Bleeding is also a complication that can occur, in particular at the incision sites. Things that can determine the success of a bypass are the health of the arteries that you're tying this bypass into. If the arteries themselves are not very healthy and don't work great already, if you're tying in a bypass onto either end, it won't be able to propagate blood as it needs to. The minimally invasive procedure called arteriogram, which we offer here at ECCO Medical, doesn't involve any incisions. It's done outpatient. It's just done with the needle stick. We do it here in the office. It involves a needle stick into the artery using ultrasound and x-ray guidance, and then using a series of tiny little wires and catheters to get through the plaque and then break it up and balloon it open. It's the exact same procedure that they use for hearts, like heart catheterization. We're just doing it in the leg instead. This has about the same success rate, sometimes a little bit higher than bypass. However, the complication rate goes from 33% to 1 to 5%, depending on the severity of the disease in the patient. Most of the complications here have nothing to do with the leg that's being treated, but it's really the access point where we stick the needle into the artery. You can get bruising, you can get some bleeding, but otherwise very low risk, usually in that 1 to 5% range. One of the things that's nice about arteriogram is that every single patient is a candidate for at least an attempt at arteriogram. Not every patient is a candidate for bypass. That can depend on a lot of things. Where the arteries are open down low, if they're not able to tie into a blood vessel, then there is no bypass ability. Otherwise, we can try to get a wire across any lesion, no matter the length. And if we can, then we can open up the blood vessels and have good success rates. The way we do arteriogram is using x-ray equipment and ultrasound equipment. So usually we're going to go through a needle stick in the groin. Sometimes we'll go through a needle stick in the ankle, depending on which one gives us the best opportunity to have success. So we use ultrasound to look at the blood vessel. We advance a needle under ultrasound guidance into the artery. We thread a wire through the needle's hollow. That wire we can see on x-ray. We can see it on that screen. And then we thread little tiny tubes or catheters. Catheters in our world are any flexible hollow tube, no matter the diameter. A lot of people think urinary catheters. The ones that we're using are going to be 1 to 2 millimeters in diameter, so pretty small. We use that catheter wire system to try to get through the plaque in the leg, in the arteries in the leg. And then once we're through the plaque, we can then do things like atherectomy, which is removal or breaking up of the plaque. In this case, we use a laser to do that. After that, then you can thread a balloon over that wire and then balloon the plaque open and restore flow. In some instances, we would need to place a stent, which is like a chicken wire tube, essentially, usually measuring about 4 to 6 millimeters, which is very small, about 1/4 of an inch in diameter. And we would place that in the blood vessel. That would be a permanent implant. And that would keep the blood vessel open to allow blood flow to get down to the feet and toes to prevent anything like limb amputation. After any procedure, whether or not it's bypass or whether or not it's arteriogram, the patients are going to need to be on some form of blood thinner for some amount of time. And it could even be permanent, depending on the extent of disease and whether or not it comes back. So if you've never been on a blood thinner before and you do get this procedure, you need to count on being on a prescribed medication called Plavix. And then we also add in over-the-counter aspirin for at least 3 months. We do regular follow-ups at 1, 3, 6, and 12 months after the procedure. If at any time everything looks really good and we don't think you need the blood thinner anymore, then we will stop it. However, if you have multiple issues with multiple parts of your body, you may need to stay on that blood thinner for quite a bit longer. One of the things that I really want to emphasize with any patient that has a recent diagnosis of peripheral artery disease or PAD is that this is a disease. I really want you to focus on that D in PAD. This is not a condition that just has one treatment and it's all gone. About 35% of patients that need a procedure to treat PAD need a second procedure for the exact same thing within the next 12 months. This plaque can come back. It's a disease process. Now, about 2/3 of patients only need it once. However, 35% is a really big number. So one thing that I really want every patient to understand is that when you come to a physician like me or a vascular surgeon or anyone else that treats PAD, you may be seeing them quite a bit. And you may need multiple procedures to get you to a point to where you finally don't need any more procedures. But everyone just needs to understand that this may just be one procedure. However, a little bit more than 1 in 3 patients do need at least one more procedure within 12 months after the first one. The minimally invasive procedures we do at ECCO Medical are outpatient. You walk in, you walk out, and they're very low impact on your body. We use moderate sedation for the procedure, so you're snoozing or completely asleep throughout the procedure, but we're not putting a tube down into your lungs to breathe for you like you need to do with general anesthesia. In general, people don't remember the procedure. They may remember a flash here and there, but for the most part, you don't remember anything about it. It's safe. We do it here every single day, and we have skilled and trained staff to be able to administer these medications safely. If you have any questions that weren't answered while you were watching this video, or if you think of anything afterwards, please don't hesitate to ask me or one of the providers that you speak with. We're always going to be available, and you can always call us if you forget to ask us something during your consultation.